EM board bombs.
Welcome back to EM Board Bombs. What's up, Briggs?
Happy to be here. Look at
I
this.
know.
The gang is back together.
The gang is back. The OGs are back. We have some exciting stuff going on.
Absolutely.
Before we get into that exciting stuff, though, hey, let's just get into it. What do you think, Briggs?
Totally. Dive into it. EM Board Bombs back at the Blue Collar Podcast.
The stem I'm going to tell you is like legitimately a stem that I had. So
with some liberties, obviously.
Yeah, with some liberties. So
some liberties.
It's a super, sick patient cannot be identified. But this is wild.
Of course.
So
age and name are changed. Everything.
And some other stuff.
Everything.
A 45-year-old male presented to the ER after EMS was called out with the chief complaint of hypotension and bradycardia. And again, that wasn't the patient's chief complaint. He was just passing out, but that's essentially what EMS called over. He told EMS he overdosed on his Seroquel because he wanted to harm himself. He required atropine by EMS. Heart rate improved, and it improved to like in the 60s. It was in the 40s when they got him. And blood pressure was still, quote, 70 over palp. I love that. When my EMS crew says something over palp, it is like one of my favorite things.
You know it's real.
You know exactly what's going on. And you better get that recess room ready, right? So on arrival, his vitals are blood pressure, 78 over 50. Heart rate, 38. Glucose, 48. Patient's mental status is, not great. You ask what he took. He annoyingly looks at you and says, I told you already, I took a bunch of my Seroquel to hurt myself. Why do you keep asking? You ask again, hey, did you take anything else? Again, you push him. And he says, I told you, I took a bunch of my Seroquel. And you're like, nothing else. And he's like, well, I took a bunch of my heart medicine, but I did that because I felt like it would make me feel better.
Oh, man.
You ask him what, quote, heart medicine this was, and then he looks at you annoyingly.
And you're hoping it's just furosemide.
I know, right? Like heart medicine. And then you're able to look in Epic. You find out that he's given a high dose of Toprol XL. And you go back to him. You confirm that he took more than 20 tablets of his extended release metropolol.
Oh, man.
EKG shows sinus bradycardia. I know, right? EKG shows sinus bradycardia with a QRS of 160 after airway stabilization and IV fluid boluses. Which is the next best step? Is it A, atropine, B, high-dose insulin, C, glucagon, or D, sodium bicarbonate? Briggs, what is it?
Correct answer is going to be C, glucagon. That is technically the next step.
Technically, but
it's not the real next antidote. We're going to tell you what's going to be on the boards, but what is also going to be real life for this really, really sick patient. This is like one of the most feared overdoses.
It really
I'm honestly
is.
shocked. Let's be real. I'm honestly shocked this is just not more common. So many people are on beta blockers. I mean, it's kind of crazy that
yeah, exactly.
this isn't that big of a deal.
It
I'm
really
always
isn't.
amazed at how rare this is.
Yeah. It is one of the
know.
fun ones to take care of. I mean,
Yes.
you feel for the patient,
very intense.
but it's definitely intense. It's definitely, it gets all the gears kicking.
Hey, speaking of intense, it's time to talk about rapid bombs.
Let's go.
EM rapid bombs. Wow, we are just everywhere nowadays. Everywhere you look, it's EM rapid bombs, EM board bombs. EM rapid bombs is our premium podcast. Check it out. We have contracts with several different residencies now. We have hundreds to thousands of people signed up for EM rapid bombs, and we deliver you just rapid, multiple choice, quick learning, coaching, telling you what's on the test as well as what you need to know for real life, and it's pretty awesome. So check it out.
Check it out. 4 to 5 minute long episodes. We keep it short bursts, and hey, shout out to our Instagram account that's been popping.
Look at that growth.
I know, right? Sign up. We are finally on Instagram. I guess that's the place to be. and we are finally putting some effort into it. So look for us on Instagram. We like to drop a lot of high yield pearls there.
And memes.
We love memes.
Lots of memes.
So
the memes are the funniest, let's be real.
We're going to break this apart, Briggs, into 2 episodes. So the first episode is that recognition part and how you're going to be tested on that recognition. What are some of the differences between beta blockers and calcium channel blockers when it comes to how to separate, right? And then we're later going to, part 2 is going to be talking about some of the more advanced treatments as well. So let's talk about that presentation, Briggs.
Definitely, yeah. So what we just said a minute ago, so many people are on beta blockers. Millions of Americans are on these medications, and they're generally very well tolerated. And the toxicity that happens, however, is extremely scary. You can imagine a medication that actively changes someone's heart rate via beta adrenergic effects and beta blocking. That is going to be a very significant bad day. The vast majority of cases, thankfully, are accidental. They're unintentional 80% of the time. Unfortunately, in this case, as we talked about, is less than 10% of cases are going to be major outcomes, potentially purposeful, unfortunately, ingestion. Now, historically, the most common overdose is propranolol. It's one of the more commonly historically prescribed beta blockers. Now, in general, each beta blocker slightly differs in how they do this thing called the membrane stabilizing activity, how they work on the heart, how much lipophilicity, that's the fun word, that they have, meaning that they distribute across the CNS barrier, how selective they are to beta 1 versus beta 2 receptors. Does any of that matter for you? No.
No, we're not getting into it.
Absolutely not. The most important thing you need to understand is that the average half-life of an immediate beta blocker is about, immediate release beta blocker is about 2 to 8 hours. And an extended release, like this person just took, is going to be delayed up to 24 hours, which is frightening. Now, that does buy you some time to quickly act and do some measures, but in terms of observation, in terms of the care that they're going to get, it's going to be a little bit different. Now, let's talk about these vital signs. So the classic memory game you have to play in terms of what is that classic pattern you see if someone just says, hey, beta blocker overdose, what do you got? What are you going to look for? Because we all know TCAs is the wide QRS, the tachycardia, the ultra mental status. For beta blockers, it's going to be bradycardia. So it's going to be the low heart rate, which makes sense because they're blocking the beta receptors in the heart, which means heart rate reduces. And then it's going to have a profound effect on hypotension. When you reduce that heart rate so much, it's going to result in a low cardiac output. So bradycardia, hypotension, low cardiac output, that is 100% going to be beta blocker overdose. We have to mention, just because we have to mention it, calcium channel blocker overdose. Now, we're not going to talk about that this podcast. Most of the treatment pathways are actually very similar, but we're just going to focus on beta blockers. Some other things you got to think about, though, in terms of your differential, especially in elderly patients. They come in with vomiting, diarrhea, maybe some blurry vision. This should ring some alarm bells in your head. You have to think about digoxin overdose. And then, of course, hyperkalemia alone can cause bradycardia and weird EKG changes. Why don't you dive into more of those specific, really unique high-yield findings that come with beta blocker overdoses? I think there's 4 different things you got to think about on the lines of what I was just talking about.
Sure. Beta blocker overdose, 1, CNS depression. So remember, lipophilic beta blockers, especially propranolol, they're going to cross that blood-brain barrier, alter mental status, seizures, coma. 2, hypoglycemia. It's more common in pediatric ingestions and non-selective beta blockers. Remember, calcium channel blockers here are what? Hyper. Right? Beta blockers, hypo. Conduction delays is number 3. Sodium channel blockade. In fact, you might have some QRS widening, some ventricular arrhythmias. 4 is going to be respiratory depression. Again, that's going to be both from CNS depression and low cardiac output. So 4 key things there.
Right. And just remember that kids are so susceptible. This is like one of those one pill can kill drugs, like the sulfonylureas we talked about before, and calcium channel blockers and beta blockers. I'll never forget as a resident, I was like I think a first or second year resident at the Peds ED, and I remember specifically like a toddler was brought in and accidentally got into the grandmother's purse, and I feel so bad for the grandmother. They were just distraught. It wasn't their fault. And the child got in and ate like 1 or 2 of the amlodipines, and it wasn't like everyone came in and they were kind of joking around. They're like, oh, we just wanted to get checked out, and then like over the course of like 2 hours, the kid declined, and it was very scary, very sad, and the family's distraught. So even this is just that one pill that can kill a child. So keep that in mind. Don't ever dismiss that in pediatric patients. So as with any ingestion, we do this. We've done this before when it comes to drug ingestions. I've talked about TCAs before on this podcast. We talked about digoxin, iron, toxicity, everything. Any ingestion, the same spiel applies, which is going to be, critically finding out more information from extended family. Now,
Right.
in this case, you did a great job of asking really purposeful questions and really being pretty, what's the word? Non-Southern about it, very forward. You were very New England about
Just
it.
blunt.
Yeah, you're very blunt. Yeah, very blunt. And from our experience in Maine, we learned quickly that people are very blunt.
Yes.
And it's appreciated.
Yeah.
But
sometimes in the South they're not.
but in this case, it may have ruffled some feathers, but you did the right thing. I definitely have never been accused of ruffling feathers. You know me.
Moving on.
Moving on. So relying heavily on family members, friends, and EMS is so important here. And so if you have the chance to get a number of family member, call it. If there's ever any doubt about what they took. EMS, so helpful.
Yep.
I always ask EMS specifically, hey, any empty pill bottles on the house? Any pill counters? Was the medicine cabinet open? Did you look and see what other things were there? Because they said they could have taken a bunch of Motrin, but then you learn further, actually that was 2 bottles of Tylenol they took.
Right.
That's completely different.
Exactly.
situation.
And Briggs, like the key thing here is, and they're going to ask this on oral board. So oral board's tip here is when you're dealing with the ingestion, you are going to be expected to reach out to more than just EMS, but family and other folks to figure out co-ingestions, right? They're oftentimes not going to tell you the full story on oral boards.
Totally.
And that's why when things just aren't making sense, especially when it comes to like the vital signs, you need, or even the mental status, like the Seroquel, we were like, well, the mental status can kind of be explained by the Seroquel, but the vital signs, are not making sense. You need to push hard on these patients to really find out. Even if it means like calling the pharmacy or figuring out where the patient's pharmacy is to really figure out what meds they're on.
And we've gotten law enforcement involved in the past too, and sometimes law enforcement may have to be called to go to that residence as well and get a list of pharmaceuticals as well in certain situations. So again, specific agent, the amount ingested. Sometimes they come with their bottles. That's helpful. The pharmacist, if you have one, I'm speaking from an ivory tower perspective, but you yourself or the pharmacist or pharm tech can count through those pills and look at their refill date and see, okay, does this match with how many they've been taking, or do they just take more than necessary today and they just got it filled yesterday? These are important things. Anyway, moving on. So the presentation we talked about, bradycardia, hypotension, most common initially, and that progresses to the worst day of their life potentially, which is going to be myocardial depression, cardiogenic shock. It is so dramatic, so rapid. I've seen it, and you have too, obviously. It is very scary.
And that cardiogenic shock,
0 to 60.
Yeah, that is 0 to 60. It really is. It's like
so
that. It's like that Ron Burgundy meme, right? Like this escalated
got out of hand
quickly.
fast.
Yeah, this escalated quickly. That cardiogenic shock. Here's a pro tip. This is something toxicologists will oftentimes recommend. So that beta blocker overdose, they are progressing hypotension, bradycardia. Do a quick bedside ultrasound while you're doing your other interventions, because that is going to be one of the most reliable things that you can do at bedside to see if some of the interventions that you are applying are actually helping. That's something that a lot of toxicologists will push, especially with the readily available, bedside ultrasound. So serial bedside ultrasounds to really see treatment response.
Absolutely. Shortly after this myocardial shock happens, it's going to decrease perfusion of the brain, and the drug itself can cause CNS depression. And so very quickly, ultramental status will settle in on these patients, a delirium, coma, maybe even seizures. And they're more common with the hypotension, though, just because of that shock.
Right.
And we talked about, of course, the hypoglycemia already. Now, the lab studies are really just not that helpful. The history is so important here. The labs are going to show just general, shock-like presentation once it's settled in. And obviously, serum beta blocker concentrations are never available in ED. But the other labs you're going to get, and this is a general, again, just tox point, you're always going to get an EKG, of course. You're going to get that finger stick glucose when they arrive, CBC, CMP, blood gas, urine drug screen, even though it's not going to help that moment. And of course, acetaminophen and salicylate levels, because co-ingestions always happen, just like this guy. He was taking a Seroquel, decided to take some of his beta blocker, and then who knows if he would have taken a whole handful of Tylenol or aspirin as well.
Right.
And so always understand that that's such a classic thing. Now, we did mention the hypoglycemia and hyperkalemia earlier. These are classic findings. They're not always reliable. Actually, one of the major beta blocker cases I had did not have hypoglycemia. So on the test, it is absolutely Bohr testable. But in real life, it's actually hit or miss.
Is Bohr testable, but real life, not necessarily.
Don't just use that to don't use that to tell the difference between calcium channel blockers or beta blockers.
Exactly. Calcium channel blocker, remember, hyper, beta blocker, hypo on boards.
On the test, definitely. EKG findings we already covered here. You're going to see just that, I would say kind of a general, if you took the QRS complex, if you're watching on YouTube, you get nice hand signals right here.
You see a lot of hand signals today.
A lot of hand action here. So in general, you take the QRS and just kind of pull it out like a party popper. That's what's going to happen. Yeah, there we go. That motion. There we go. That motion. And it's going to be that prolonged PR, bradycardia, QRS widening. A lot of people don't think of beta blockers and calcium channel blockers this way, but they really are sodium channel blockers. And it's just like TCA, it's just like cocaine, it's just like lidocaine and other of those sodium channel blockers. It's going to cause membrane destabilization and QRS prolonging, and sometimes QT prolongation too. So, will our patient recover from this? What treatment is needed?
Yes. We'll talk about it. And
Stay
some controversies.
tuned.
And some controversies how to start those treatments in real life.
Did Iltafat get in trouble with the poison control? Did Iltafat have his photo put up on a bulletin board?
We might have delved fully into that, but we might, low-key.
Can't wait. The drama unfolds.
Can't wait. Hey, let's wrap it up. Beta blocker overdose. Shuts down sympathetic tone. Leads to heart rate really slowing.
Shuts down.
Hypotension. And in severe cases, cardiogenic shock. Remember, bedside ultrasound is actually really useful here because you can get a baseline for that cardiogenic shock. You can also see how your interventions are doing after that. Non-selective beta blockers like propranolol, carvedilol, be on the lookout for CNS depression and seizures here because they're very lipophilic in nature. They're going to cross that blood-brain barrier, right? Notably, beta blockers can cause AV block and, again, cardiogenic shock. The diagnosis of beta blocker toxicity is clinical, but on EKG, it's really going to be showing bradycardia, prolonged PR interval, and possibly AV block. That can raise your suspicion if you're not 100% sure if this is coming from beta blockade. A couple other key things, boards will kind of mention or allude to in labs. Hypoglycemia and metabolic acidosis are also common in this medication class. Anything else, Briggs?
Subscribe to EM Board Bombs, EM Rapid Bombs.
Let's
go to emboardbombs.com, baby. emboardbombs.com. I need to enunciate more. People at work look at me when I tell them the website, and they're like, what was that?
I think I would say that in general for you, but I find it an endearing quality about you, Dr. Briggs.
What, that I talk too fast? I know.
And the lack of enunciation. It's fantastic. Don't ever forget. Don't
ever
stop.
Change.
Don't ever change. Don't believe what they say.
It's the New Englander in me.
Yeah, okay.
Fast talker. They talk fast up there.
We got Tennessee and North Carolina here. Let's be real, okay?
I'm not from here originally.
Ain't nothing about us that says New England.
Right. Yeah, we were like fish out of water up there.
Let's be real.
That's great.
All right.
Yeah.
That's it. See you next time.